Great. Thank you very much, Dirk and PK. Fantastic conference. It's an honor to be here to talk to you about my toolkit for wires and support catheters below the knee. Well, I have a three-layered box I'm going to talk about, and number one we'll spend the majority of time on, but it is a three-layered box. The first is the wires and catheters, and for me it's V18 control wires and Command 014 and 018 wires, and quick cross catheters of multiple lengths, but you can use CXI and others, whatever your favorite one is. And then you have your own CTO and also the glide wire advantages and the FR4 bright tip. Layer 2 is all the adjunctive stuff that you've seen in all the live cases that you're seeing here that we've just discussed, but you need to have those. That's not the point of this talk. And probably the third layer of the box is the most important, and that is truly good judgment on your behalf. Are you doing the right procedure at your point in your career? And then all these others, creativity and resourcefulness, as you're seeing PK and Andre and others utilize, are probably more important than anything. My thoughts are a lot, we've been expressed here, we have a little bit of differences. I try, like, for the vast majority, to do the work, definitive work, from above, from antegrade. We cross with wires and catheters in their interaction together. I don't even have a crossing device like the crosser in our lab. You're always going to need access from above, both for angiograms and for your definitive work, and we try to wire antegrade first. Unlike what Art was saying, we don't use sheaths very much distally. I try to just use bareback catheters or balloons and then get them out sooner unless we think we have to work from below. And you really need well-prepared patients, Foley catheters, hydrated, informed, and enough time allocated for these procedures that can be long. So let's highlight that with some cases. Here's somebody at CLI. They had one vessel runoff, and it was via a diseased peroneal down here. That's all they had. They had an anterior tibial. They had a lot of two occlusions in the past. So we were able to get through that long occlusion of the stents before and stay in the lumen and get a wire into that peroneal. And our plan was to clean it out. Here was a jet stream, and then do definitive therapy with DCBs. We had a full basket, so we exported into that, and we actually had a very unusual retrieval issue here, and despite leaving a wire behind here while we got the filter out, we had a dissection issue, so we had to rewire. Again, this is a Command 014 into that stent, and then there's your adjunctive IVUS. Again, here's just a section. Remember what we had before and above and below. This is a short Sapera. But getting into the toolbox, we really wanted to get that anterior tibial open because we were going to reline this. It was the third time around, and you need better runoff. So we couldn't get their antegrade. And this is just the example of going retrograde in the anterior tibial, using your wire catheter interaction to slowly go up here and then slowly go around that bend, and then pay attention to your feedback and just go back and forth with your catheter right there, and then you're able to wire that. And then here's your FR4 bright tip, as you've seen many times, and your one drug-eluting stent. And now we're able to reline this with two good vessel runoff. Here's a 93-year-old we did a couple weeks ago. One of our surgeons had done a right femoral endotorectomy and a bunch of stents, and they had cold leg after that. We knew they had a left common femoral artery occlusion. Unfortunately, they had some issues with the stent, and you can see the distortion. And then the entire stents that put in less than 18 hours ago were occluded, and it took out the AT and the PT. So we were able to get through there, but usually when you get through these stents, it's very easy. We could not, and what we found out with IVUS and looking at his films is there was a significant dissection they stented into. So here's peroneal access. Again, you rotate the camera so that you can see between the bones and access. Again, here's just a wire, V18, and a catheter, and then working your way up and into the FR4 bright tip and externalizing. And I learned from Miguel, instead of diddle-daddling, as you said, I'm going to now just take that catheter up and around and then finish the job, and we're able to get flow back in a good bifurcation. Here's somebody who had a couple failed attempts at an outside place, and they had dissected this pretty badly. You can see there's additional popliteal disease and dissection from their first work, and they had gone posterior tibial, and there was an occlusion there. and there's a PT occlusion where they had worked before. So we went peroneal and got our wire up here. This is the first and only time I've ever seen this. We had a coated wire that got this conglomerated ball on the peroneal axis. I couldn't advance anything. We're going to have to fix that later. So now this is just the PT axis above that occlusion. And again, it's just a catheter and wire slow interaction till you go up. Every now and then it's hard in two dissection planes. So here's the cart that you've seen many times. That almost always works. Occasionally, as Dirk and others have taught us years ago, if you really have to, up here above the knee, you can puncture a bareback balloon from below with an outback from above. Separas here. And then we had the posterior tibial occlusion. And we crossed that antegrade very carefully with a command wire into the foot. And final work. Finally, sometimes you have to be creative. As Art says, I think for a lot of books, if you know you're going below the knee, antegrade access, getting your sheath close is good. You can see a long AT occlusion. We tried antegrade, but really couldn't get there despite several attempts. So again, retrograde is the next option to get through this occlusion. Here we got very close, but couldn't get in retrograde. Before we do cart in a small balloon, one of the things you can do is simply try, now that you've made a channel up here, now all this is trying to antegrade wire and have the wires meet. And now we're able to get a wire antegrade, just facilitated by crossing from below with a catheter, confirm our position. And here are drug-eluting stents in the anterior tibial and result. So in conclusion, your BTK toolbox should include 014 and 018 wires and support catheters. Majority can be crossed with meticulous technique. It just requires a lot of patience, creativity, and good judgment. Thank you very much for your attention.